You're here for pharmacodynamics, correct? Yes? Someone's having a PTSD flashback, like a nom sort of thing going on. Okay, so we're talking about fluids and electrolytes today. Yeah, I feel kind of like toothless up here right now because I have like no leverage over any of you. I don't write any tests for you anymore. Kind of weird to have no power, but anyway. Anyway, you guys went through the gauntlet. You've survived all my tests, so congrats. This is my victory lap for you guys. Anyway, okay, so today we're gonna cover issues of fluid replacement and maintenance. I'm mainly going to cover like IV replacement of fluids. Again, this is something that seems kind of like a no-brainer. Seems pretty basic. Like we're giving some normal saline. What's the big deal? There's lots of ways you can kind of screw this up, and so we're going to try to show you how to have appropriate fluid decisions as far as like what fluids we're going to use, how much we're going to give, some of the pitfalls you can run into. So that's kind of the main things we'll cover today, and then we'll look at some cases and see what we think are going to be the best options for those patients. Okay, you guys are able to get this from the website from Canvas? Perfect. All right, so back to being serious. All right, so imagine we have a 34-year-old male patient who's 80 kilograms. He's come into the ER, fever, has some vomiting, diarrhea, he's got some gastroenteritis causing this, and appears to be dehydrated, but he's unable to tolerate any kind of oral fluid replacement. So you decide to admit him, and he's going to be going inpatient for rehydration therapy through the IV. You can see his vital signs there. He's got a heart rate of 120, BP of 95/68, temp is 39. So first question, what do you notice about this patient? He's tachycardic with hypotension, right? So again, does that make sense based on dehydration? Right, good. So again, we have too little volume within the vasculature to cause adequate blood pressure, and then the heart responds by what? It wants to increase cardiac output to account for that decrease in systemic vascular resistance, right? So kind of going back to that basic kind of cardio concepts there. So right, so you expect the patient to be tachycardic and be hypotensive. That totally makes sense based on that kind of dehydration picture. So first question will come up is like, well, what kind of fluids do you actually want to use for the patient? Is LR a good decision? Is NS, half NS with D5W? How do you make that decision? You said just use NS. Okay, so you maybe want to get some laboratory evaluations and look at their CMP or their BMP to see what their electrolytes are looking at. Good. What electrolytes of note were you interested in? Sodium's good. What else? Potassium's the other big one. You can also look at what else? Calcium's not going to be as important here, but bicarb, I heard bicarb, that's a good one. What other thing comes on the end of your fishbone on your BMP? Chloride, not so much, but at the very tail end of it, the right side. Glucose, you want to look at glucose as well, right? So you want to make sure, especially if the guy's having a lot of nausea and vomiting, diarrhea, he's probably not intaking a whole lot of food in addition to fluid, so he's probably run the risk of being hypoglycemic. So you want to check his sugar as well, right? The question is, well, then once we decide a fluid, how much should we give? A little bit? Do we give a lot? We'll look at some of those factors that go into making our decision on what we're going to actually use for those patients. Okay, so again, kind of introduce the case here. We'll go over some, some details of how we're going to make these decisions. We'll come back to this a little bit later once you have a little bit more information. Okay. So looking at our body fluids, how we're actually going to be breaking these down, and again, some of this might be a little bit of review, that's okay. Looking at total body water, so usually about 50 to 60% of body weight is making that up. And then we can break that down into both the intracellular fluid, we're going to have a little bit of transcellular fluid there, and then also the extracellular fluid. And again, our blood is going to be maintaining a lot of that extracellular fluid. You can then break down extracellular fluid down into the intravascular space, and then the interstitial space is also going to be making up a lot of that. Okay, so again, one of the things you'll notice is like kind of where the lion's share of these electrolytes are going to be lying. Notice in the intracellular fluid, it's mainly going to be potassium making up a lot of those positive ions. Notice in the extracellular fluid tends to be more sodium. Remember how the analogy I used for your cells? Salt, rat, banana. I'm glad you guys remembered that. That's great. I got the same bewildered look when I told the first year students as well when I said that, but hopefully they will remember it just like you did. Everyone remember that? Anyway, so yeah, so again, sodium is typically responsible for that extracellular space. Again, when you're looking at osmolality of the blood, typically you're shooting for somewhere around 300 or so, usually 275, 295 milliosmoles per kilo would be considered a normal osmolarity, right? And again, I always mix them up, so I'll call it osmolarity. Don't sue me over that. Anyway, in the intracellular space, it tends to be more potassium being the big mover and shaker here. Now, here are the common fluids you may administer to a patient IV. Some of the things I want you to know, obviously, is the dextrose concentration. Then we're going to look at sodium, chloride, and then the tonicities. Remember kind of the concepts of hypo, iso, and hypertonic solutions. That'll be important when we're looking at where we want to send those fluids as we infuse it into the patient. Okay. Based on that, based on tonicity, you can determine kind of what percentage of that fluid should end up in the extracellular space, should remain there, and then what percentage is going to go into the intracellular space. Okay, and then based on that, it kind of gives us an idea of what we call free water. Anyone know what free water is? So that's what you can get from the tap. But yeah, it's basically how much fluid there is free that can move into the intracellular space, essentially, right? So one of the things we'll see is like with dextrose, while it does have a tonicity to it, you're going to find that the dextrose really quickly gets uptaken into the cells. It gets broken down very quickly, so it doesn't stick around, and so you're basically left over with just water, essentially, at that point. And so that's why you're going to notice a lot of this will end up more in the intracellular space, and then we call that, basically like a liter of free water, which the patients say is like edematous, so they already have too much fluid in the intracellular space. This may not be a good thing for them, right? So in some cases you may give D5 by itself, but it's not super common, right? Because again, you don't want all that free water, especially in a patient like we just mentioned who is intravascularly depleted. We know that because he's hypotensive and tachycardic. We want that fluid to go into the intravascular space, right? So next up, we're looking at something like half normal saline, right? Why do we call it half normal? It's half the concentration of sodium as normal saline. Normal saline is what? 0.9%, right? So this would be 0.45%. You know what quarter normal saline would be? 0.22, yeah, so 0.22 would be quarter normal saline. So you use that occasionally. But you notice here the concentration of sodium and chloride are going to be equal between the two because one sodium for every chloride. And typically this is also going to be a hypotonic fluid. So if you had to guess, where do you think that fluid is going to end up? Extracellular or more intracellular? You're going to think more intracellular because, again, remember osmosis and remember where this fluid is going to be ending up. Again, if the concentration of solute is higher within the cells than it is in the fluid you're administering, it's going to cause that water to shift over, right, to shift into the cells. And so, again, if you were to look at this, you see that, a decent percentage stays in the extracellular space, but you're going to notice that more of it goes in the intracellular space than something that would be, say, isotonic, okay? Again, this is less free water, roughly just half a liter per liter versus something like just D5, okay, D5W. Next up is ringers, lactate or lactated ringers. Where do you see this being used commonly? Yeah, surgery is a big, and I'll talk about why that is a little bit later, but basically you're going to find this has, pretty close to normal serum concentrations of sodium located within it. What's a normal serum sodium? Yeah, 135 to 145 or so is a good normal number there. Again, this is considered isotonic. So usually your two main isotonic fluids you're going to administer to patients is going to be lactated ringers, and it's going to be normal saline, right? Or normazoline is like to call it for drug seekers who are looking for something like, I got a really good drug for you, normazoline, we give you a liter of it, that's how much I'm going to give you, and make you feel great. Yes, sir?
Are the percentages incorrect on the half normal saline?
I don't believe so. No, yeah, so this is going to be accurate. So again, not all that fluid is going to be traveling into the intracellular space, but you're going to find there's going to be a larger percentage of it lies there than you would see for something like D5W, right? Versus when we're looking at normal saline, we're going to see 100% stays in the extracellular space. And so those concentrations would be accurate for that. That's kind of what we've seen based on how we take care of patients essentially, right? So anyways, lactated ringers, normal saline, you should have normal, roughly normal serum sodium concentrations here, close to that. Again, these are both isotonic. So when I administer this, most of that volume should stay within the extracellular space, and primarily, especially for a hypotensive patient, I want that to be in the vasculature. I want that to be filling up the vasculature to try to get that pressure up. That way, I can hopefully get the heart rate back down. So again, in this case, we would consider these to have no free water. You shouldn't really have a ton of it shifting into the intracellular space. However, sometimes we use hypertonic fluid. Anyone know why we might use that? Right, so just like we might use a hypotonic fluid to put water into the cells, I can use a hypertonic fluid to draw water out of the cells. And so in this case, you can use something like 3% normal saline. When would I want to do that? Yeah, so if you have increased intracranial pressure, you have cerebral edema. I'm sorry if anyone in the back says it, but I'm probably going to have a hard time hearing you. So if you shout it really loud, I might be able to, but the Pharm is going to get more attention there. But anyway, if you give 3% saline for someone who has, say, like cerebral edema, they have a lot of fluid buildup in the brain, you can pull that out by using a hypertonic fluid. And that's where something like 3% normal saline is going to be coming in here, or sodium chloride. So this is hypertonic, and there's a very high concentration of sodium. All the fluid, again, is going to stay in the extracellular space. In addition to that, you're drawing fluid out of the cells and into that extracellular space. So again, this has a negative free water amount, about -2 liters. So it's very, very potent at pulling that out. Again, you would never give a whole liter of 3% saline to someone unless you really didn't like them, because you'd kill them. You don't want to do that. So we'll look at some other uses for this going forward. Yes, sir?
What do you mean by free water?
Free water is basically water that's going to be free to go leave the extracellular space and go intracellularly, essentially, right? Okay, so basically when looking at fluid balance, and again, how can I determine fluid balance in a patient? I's and O's, right? So I look at what I'm putting into the system, I look at what I'm getting out of the system. Do I and O's give me the full picture? No, they give you the majority of the picture. However, we're going to talk about sensible and insensible losses. What would be an insensible loss? Sweating, what else? Some breathing, right? So I'm breathing off some moist air. Anything else? If you're like losing water in the stool, you might not be calculating that all the time. So it just depends. Looking at fluid gains, though, typically your things sensible being things like oral intake. We don't typically consider the actual water that's in the food we're intaking, so that can be, but that would be considered sensible still. Then oxidative metabolism. You guys remember like the Krebs cycle and electron transport chain. The newbies have their test tomorrow in this stuff, so they're trying to furiously memorize that. But you do get some water generated out of that. That would be considered insensible. This would be impossible for us to really kind of measure directly on the patients. Looking at fluid losses, though, sensible tend to be like urine and stool, the most common ones, but again, lungs, skin, those tend to be the more kind of common insensible losses you see for your patient. And these are things that are very difficult to measure, or nigh impossible to do so, and so we know that they're still losing that fluid, but we need to take that into account. So again, I's and O's are good. They give you the majority of the picture, but not the whole picture there, right? But again, typically you're going to be seeing that you should have kind of a net negative, or I'm sorry, net neutral sort of balance there. You don't want to have an additional ton of extra water coming in. You want a ton of extra water leaving the system, essentially, right? Typically, an average adult patient should get anywhere between 30 to 40 mLs per kilo per day. That's what we would consider to be a typical amount. When we're doing things like TPNs, anyone remember what that means? Total parenteral nutrition. Yeah, so when we're giving them food via the IV, basically, this is kind of the fluid volumes we're kind of shooting for, because we know this is how much they would normally be intaking for just an average healthy adult. So, what are some reasons for additional fluid gains or overhydration? Why might the patient have too much water? Good, yeah. So to polydipsia, they have lots of reasons for that. Like I always think about from a tox standpoint, think about things like ecstasy. Sometimes patients will develop this kind of psychogenic polydipsia, where they'll just intake a ton of water, and they can definitely get overhydrated, definitely develop some edema from that, right? What are some other things? I guess that's going to be an issue where you can't eliminate fluids potentially, right? So the kidneys are not working that well. That could be one thing. Those are kind of the main ones. So I'm either intaking too much or I'm not getting rid of enough fluid. That's going to be kind of the main things you're going to see for kind of overhydration. About reasons for dehydration. Sports, yep. So you're out there running around. You're going to be sweating a ton. Absolutely. What else? Diarrhea, vomiting. Beer could be one. Oh, I thought you said beer. I was like, yeah, that does make you dehydrated, but I guess that's more of a Freudian slip on my part than anything else. Anyway, yes, if you're hyper in kind of an increased metabolic state, that will also end up kind of losing some extra water there as well. Yes, other reason for dehydration, so lots of them out there. So typically, if you were in a case where you were, say, overhydrated, say I was drinking too much water, what do you think it's going to do to the serum sodium? Typically decrease it. What do you think it's going to do to the plasma osmolality? It's going to decrease it as well, right? So I'm just taking in free water. If I'm just drinking water out of the tap, that's going to be diluting out the sodium that's there, and it's also going to be diluting out all the other solute in the blood. I'm going to see my osmolality is going to decrease, right? On the flip side of that, if I'm saying I'm dehydrated, you'd expect serum sodium to be what? Typically increase. There may be some cases where you're losing salt, right? So that's not always the case, but then your osmolality should also be what? Increase, right? So you're going to see hyperosmolality in the blood, okay? So what hormone is mainly responsible for responding to that osmolality? ADH, another name? Vasopressin, good. So antidiuretic hormone or vasopressin, these are the main hormone we're going to see that responds to this. Now, these are not the only responses that is going to cause ADH to be released, and what you find, especially in more critically ill patients, they tend to be in a hyper-secretory state of ADH. They're releasing too much of it, and so you're going to find, especially in hospitalized patients, they tend to have a higher propensity to develop hyponatremia, and then we're not helping with that, as we'll see on our fluid selection. This is actually one of the most common med errors that happens in the hospital is iatrogenic hyponatremia that we're actually causing for the patient. A lot of it goes back to ADH. So normally we think of the hemodynamic stimuli for ADH, so things like volume depletion, right? Things like hypotension. That is going to be stimulating the hypothalamus, that then stimulate the pituitary gland to be releasing ADH, and then we're going to be causing water to be retained, and hopefully it will increase our blood pressure, right? Things like CHF can increase it, cirrhosis, nephrotic syndrome. But the other things you don't always consider are going to be the kind of non-hemodynamic stimuli. So patients are in a lot of pain and stress. They tend to be in a state of increased ADH release. A lot of nausea and vomiting, like our patient we were already talking about, maybe seeing there. Hypoglycemia, medications. Several medications can cause increased ADH release. So lots of different things here, right? Again, a lot of things you're going to see. You're going to see this in hospitalized patients. Especially perioperative state, inflammation. Lots of reasons why you're going to have too much ADH in a lot of your patients there. Okay, and again, ADH, when that starts to get secreted, it's going to do what to serum osmolality? It's going to try to decrease it, right? Because what does ADH do? It's going to hold on more water in the kidneys, right? It's going to put in those aquaporin channels, try to hold on the water. What else does it do? Increase that thirst center, right? It's going to try to drive your patient to try to get more water. Remember I talked about, and probably you guys blocked out all those memories already, but we're talking about like head trauma patients. Oftentimes they develop an SIADH where they're having a syndrome of inappropriate antidiuretic hormone. They're releasing too much of that, and they are so thirsty. They will do anything. They will, sell their grandma off just to get some water, some Gatorade. And you had to like basically lock them up in the room to prevent them from sneaking out. They try to bribe their family members to bring them some Gatorade or something because they're just so thirsty. So ADH is a very powerful sort of hormone, especially in these kind of critically ill sort of patients. Kind of keep that in the back of your mind. So, and again, looking at electrolytes are another big component of what we're going to be replacing kind of on an ongoing basis for these patients. So you can see in things like the saliva, some of these are going to be excreted through the feces. You're going to be losing things like your sodium, your potassium, and these are going to be important to include in your maintenance fluids to make sure we're going to be kind of maintaining these ongoing losses. That way the patient does not become hypokalemic or more acidotic or hyponatremic. Okay, so we'll see some reasons why we might need to include electrolytes in just a second. Okay. So typically, as a general rule, whenever you're collecting fluid or electrolyte problems, you want to look at how quickly the onset of this has occurred. And so I don't know if you remember when we were talking about kidney stuff towards the end of Pharm 2, I think, but we were talking about adaptation, especially with like CNS adaptation to some of these changes in fluid status and osmolality, right? So again, this is something that takes time to occur because again, like especially like the blood-brain barrier, it doesn't like to have a lot of shifts that occur very quickly. So if something has happened quickly, say less than 48 hours, typically, or the patient is actively symptomatic, this is something you can fix quickly as well. Okay, so again, little adaptation has probably occurred in a short time frame, and so I can correct their sodium, I can correct their fluid status pretty quickly without really too much worry about any kind of side effects here, right? Especially if they're developing an ultramental status due to hyponatremia, I can correct that with 3% saline. It's a very fast way I can do that because it's so concentrated. On the flip side of that, if it's occurred, say, over a 48-hour period, or the patient's asymptomatic, now I have time. I have time to kind of correct this because I don't want to cause a lot of fluid shifts, like, say, in the brain. I don't want to cause a lot of fluid shifts from, like, say, the extracellular to the intracellular. I can take some time there because the adaptation is more likely to have occurred here. So, for instance, something like chronic hyponatremia, I may run the risk of overcorrecting with, say, something like 3% saline. Remember, we had that central pontine myelinolysis that occurs there, and again, that can lead to patient death, so we don't want to do that. So again, you don't always have to use the big guns to correct these issues if you have time to work with it, right? The patient's asymptomatic. Remember how much sodium you want to correct within a 24-hour period for those patients? Good number to remember, especially if you're like in ER somewhere, ICU. Usually 12 milliequivalents per liter per day, right, for a 24-hour period. Obviously, if they're seizing, you got to correct that first, but you want to do no more than 12 within a 24-hour period. Otherwise, you run the risk, especially if this adaptation has occurred, of having that central pontine demyelination, right? So, anyways, our goals of fluids here, we should be able to try to replace or maintain fluid balance, obviously, and then try to maintain or maintain electrolyte balance. Now, I will tell you, if you have a patient with an electrolyte issue, you do not want to fix that with your maintenance fluids, okay? We'll look at some cases where we're going to put some electrolytes into the fluids, but this is not going to be the place where you're actually going to fix it. If they're hypokalemic, you need to fix it outside of that bag, okay? And that's where you can have things like, if you've heard of like a K-Rider or something like that, that's actually an extra bag you're going to be administering, almost like another drug, like an antibiotic or something like that, to fix that issue there. This is really only trying to maintain balance and try to maintain, prevent further losses that would happen kind of normally in the patient, okay? And then the other thing we can do is provide calories, and that's going to be mainly in what form? Dextrose, right? We're going to give them sugar, essentially. Okay, so other potential goals we can see here is we can maintain or correct their serum pH, right? So again, normal serum pH is what? 7.35 to 7.45, right? Those are good ranges to remember. And again, do I ever run in the case where I want to acidify the blood? Not really. I've never run into a case where I wanted to acidify the blood. More than likely, they're going to be acidotic, and you want to correct that. And it's usually going to be a sodium bicarb. We'll talk about some cases where we can use that in a little bit. We also can provide oncotic pressure. You guys remember what oncotic pressure is? Yeah, usually proteins. There are going to be proteins that are going to be in the serum that help to maintain fluid and keep it there. Sodium and other electrolytes, those can go into the cells. They can be transported around. But proteins, they like to stay right there. So albumin is going to be one of the main ones we'll talk about. Albumin likes to stay right there in the intravascular space, and that provides that oncotic pressure that holds fluid there. So in some cases, you may need to replace, not necessarily with electrolytes, but replace with proteins. We'll look at some cases for that a little bit later on. Another goal you might have is to prevent things like precipitation of metabolic byproducts in the kidneys. So a good example of this is something like methotrexate, where I might give sodium bicarb containing fluids to help keep the urine at a more alkaline pH, prevent precipitation. Another big case you might do this is going to be in rhabdomyolysis. What is that? Yeah, pretty significant muscle breakdown. That myoglobin will precipitate out the more acidotic that the urine gets. If I can keep that alkalized, keep it a good normal pH for the urine, then that helps to prevent that, and hopefully keep the kidneys from being flooded with that myoglobin and prevent it from causing any kind of renal damage, hopefully. So what are the routine fluids we have available to us? So a lot of these are going to include sodium chloride. So we're going to have things like normal saline, which is 0.9% sodium chloride, right? So it means basically it's going to have 154 milliequivalents of sodium per liter. You may think like, why the heck do I need to know that? But it's good to know kind of these ranges here, because based on what your patient's sodium is, this is going to help you decide what kind of fluid you want to use. And we mentioned normal serum sodium is what? 135 to 145. So again, 154 is pretty close to that. In fact, this is good if you have a patient who's maybe serum sodium is pretty normal. Maybe it's a little bit low and you want to help kind of pick that up a little bit. Sodium chloride, 0.9% could be totally good for that, right? Or if you just want to keep all that water in the extracellular space, this is also good for that. And then you have half normal saline, you have quarter normal saline, which are used on some occasion as well. And then we have our dextrose. Now, usually when I say like 5% dextrose, you guys remember what that means? We'll do some calculations in a little bit because we want to figure out how many calories are going to be included with that. So just keep that in mind. The most common concentrations are going to be D5W or D10W. Okay, so depending on what the case is, what the patient's glucose happens to be, I might choose one or the other essentially. Okay, but again, you typically don't want to give this by itself. There's some rare instances where you do, but you don't want to give this by itself because it's considered all free water. Most of that's going to end up within the intracellular space, and we don't necessarily want that. So again, typically you're going to find dextrose in combination with sodium, right? So typically a common fluid you might put a patient on would be like D5NS or D5 half normal saline. That would be a very common thing you might see. Okay. And then lactated ringers, again, is another isotonic fluid. Again, this is used more frequently in the surgery sort of realm. You can notice here it's kind of a mixture of different electrolytes. Now, what do you think about that lactate? What do you think that lactate does for us? It's a buffer. Okay, so but you think lactate, you think lactic acid. What's that going to do for our pH? You'd think it would make it more acidic. What actually happens, though, is that lactate gets taken up by the liver and gets converted back over into glucose. So you guys remember that Cori cycle by any chance from physiology way back in the day? I have a whole YouTube series. You can go back and review all of it. Relive the memories. No, but that lactate eventually is going to go to the liver, gets converted back to glucose, and then glucose, as it gets metabolized, what's the byproducts of aerobic metabolism? ATP, but also CO2 and water, right? Remember, CO2 and water is the eventual breakdown products of the electron transport chain and all of that. That CO2 and water that can then go into the blood and can work with carbonic anhydrase, if anyone remembers that enzyme, and turn into bicarb essentially, right? So again, there's kind of a convoluted pathway, but just know that lactate eventually turns into bicarb. So that's why they like to use it in surgery realm, because again, if I'm cutting open a patient or they have a transient say hypotension, they tend to get a little bit more acidotic by giving that lactate that has a little bit extra buffering capability, okay? Again, mainly used in the surgery realm, not used frequently outside of that, but we'll show some examples in a little bit. Okay, other fluids you might run into. So we mentioned all these kind of salt-containing fluids. Remember, there was colloids and there's crystalloids. Remember what a crystalloid basically means? Contains some sort of salt or electrolyte, so basically it's all the lactated ringers, NS, D5, all that good stuff, if you consider are crystalloids. The colloids, though, tend to be more protein based. So this is where albumin comes into play. Normal concentrations you're going to see are either between 5% and 25% albumin. 5% is really good if you need like volume replacement. So again, we'll find the doses here are going to be similar between like a fluid bolus and an albumin bolus, but the 25% typically is going to be used to help replace protein that maybe the patient's not making. So anyone who doesn't make a lot of albumin? What type of patient? Sometimes a liver failure, More commonly, they're going to see chronic renal patients, like chronic kidney disease patients. They typically have lower albumin. Malnutrition, things like that can also decrease your albumin stores. So if you need to replace that, that's where we can give 25% albumin. Okay. There's some other ones. There's things like hetastarches and dextrans. Again, that's going to be more relegated to surgery. I'm not going to cover those here in any great extent. They're more expensive and they have some side effects associated with them. So kind of outside of our scope here, but albumin we will talk about because it is used more commonly. Okay, so other additives we'll routinely include with our fluids are going to include things like potassium chloride, or KCl, usually either between, like, say, 20 milliequivalents per liter to 40 milliequivalents per liter. Now, again, if you have a patient who's hypokalemic, say a normal serum potassium is what? 3.5 to 5 essentially, right? So again, the ranges may vary based on which lab you're going to, but typically 3.5 to 5, right? Now, this is only going to be good for replacing ongoing losses. So if you have a potassium of, say, 2.5, this is not the way to fix that, right? You need to give a lot more than that. You need to give it in its own kind of, specific bag by itself, essentially. But if you're just giving it as maintenance fluids throughout the day, this is perfect. You can replace that pretty easily with that, or you can help to keep those ongoing losses from being too much. Other things you might include are sodium bicarb. Now here you may find there's varying concentrations. We may put, say, only 50 milliequivalents per liter in there. We may go up to 150. We'll look at some use cases for this in just a little bit. Typically, though, if you're including bicarb, this is for alkalization. You want to increase the pH of the patient, or their bicarb's already too low, or they're acidotic. This is helpful to replace that. Okay. Now, one thing you can do in some cases is if you don't have bicarb, like oftentimes we have shortages where we can't get bicarb. We will act, and you're like, how can I not get bicarb? It's like baking soda. Like, I cannot get that, but it does happen. And so what we can do is actually replace it with acetate. So either sodium or potassium acetate. The acetate will eventually be broken down into bicarb anyway. Okay, so that's one thing you may see used occasionally. Other additives, especially if we're doing like a TPN or total parenteral nutrition, may include like amino acids. That helps provide protein for our patients. May see some other electrolytes like calcium, magnesium, phosphorus, and then sometimes lipids, right? Because lipids will provide calories from our fats, help prevent any kind of deficiencies there for those patients who are not going to be able to eat for a long period of time, who are NPO for a while. So back to the case. Going back to our 34-year-old male, he's got gastroenteritis, he's hypotensive, he's tachycardic. We want to give him some fluid. So what type of fluid bolus do you want to give him? What type of fluids do you think would be good for this guy? Without having any labs available. Normal saline would be totally a great option for this patient, right? So again, because that should be pretty close to what normal serum sodium is anyway, that's going to be a great option. It's really hard to go into to get into trouble using a liter of normal saline for an adult patient, right? Now, what else could I use? You could also use lactated ringers. That would be fine as well. Typically, the big thing here with the bolus is you want to use an isotonic fluid. Okay, fluid boluses you want to be isotonic, either LR or NS. I'll tell you in 99% ERs out there, they're going to use NS every time, right? LR is going to be more in the surgery realm. You're going to see that used much more frequently. Okay, again, most of it has to do just either cost. NS tends to be a little bit cheaper, and it's just it's going to get us what we need, and that's going to be that intravascular volume is what we're looking for. Okay, how much should he receive? 1 liter, 2 liters, 10 liters, 2 liter. You can always start with 1 liter. Right? The big thing with fluids is, guess what? You can give more. Once I put it in, can I get it out? Not without time. Hopefully the kidneys are working. Maybe dialysis. I don't want to have to do that, right? Never want to have to start someone on dialysis that didn't need it in the first place. No good. But start off with a liter. That's a good way to go. And then potentially, if he was much more hypotensive, if he was having ultrametal status, anything like that, that may be a case where we want to start 2 liters at the same time. We'll look at some different ways we can get that into the patient. But yeah, 1 to 2 liters, great way to start, right? Now, what are some cases we might want to use less? They have CHF, they're already edematous. What else? If they are chronic kidney disease patients or having acute renal failure, anything like that, any kind of acute kidney issues where they're not going to be filtering fluids appropriately, that could be another case where you want to be a little bit more careful and use a smaller amount, right? So if I wanted to, I could start with a 500 ml bolus and see how it responds, and then give more if I need to, okay? For a patient like this, though, that doesn't have any previous medical history, as far as we can tell from the case, a liter, 2 liters is going to be totally fine for them, okay? Now remember, can I use that for peds? Just give like a little, 1,200 gram neonate liter of fluids? No, you're going to kill them, right? You don't want to do that. So we'll look at those numbers in a little bit, which hopefully you guys have memorized because I've covered it so many times. Remember the fluid bolus for a kid is? 20 mLs per kilo, right? That's a good number to remember. Okay, so we mentioned fluid boluses are typically 20 mLs per kilo for peds. Usually adults 1 to 2 liters. Renal patients, you're going to start less than that, either 10 mLs per kilo or maybe like 500 mLs. That's going to be pretty standard, okay? Fluids used typically NS. LRs are going to be more in surgery, as I mentioned here. And at this point, there's no benefit to using colloids. So using albumin is not going to help us out. There's no additional benefit. Studies have shown that. And then using a liter NS is going to be just fine for grand majority of patients. Okay. Now, in some cases, say you're dealing with a patient who's coming with severe sepsis. Say they're coming in with trauma. These are cases where they've either had significant fluid loss or they're at a case where they are very kind of leaky capillaries, like especially in sepsis when you have all that inflammation. You have very leaky capillaries, they're just losing fluid, and they can't keep it in that intravascular space. You may need between 60 to 80 mLs per kilo to help adequately resuscitate that patient, right? And again, you can always give more. Can't take it back though, so you want to be careful, especially if they have renal disease.
How would you judge in a CHF patient whether to give more, whether you need more?
Oh, that's a great question. How would you do that? How do you assess if someone's got too much fluid on board? So they have like edema anywhere? How do the lungs sound? If the lungs sound really junky, that's probably a good sign they're having some fluid backup. They're having pitting edema. These are all things that may show you that, hey, they've got a lot of volume that's being built up in the periphery. It's not an intravascular space where I want it, but those are cases where, especially the lungs are the biggest thing, because that's what I'm really worried about, is causing pulmonary edema by giving too much fluid, right?
They would already have that to a certain degree, though.
It depends. It depends on how well controlled they are, how diuresed they are on a normal basis. Many factors that go into that. But again, you're doing your physical exam to kind of assess where you're at and then making that decision on how much you want to give, right? So again, if they sound super junky up there, maybe you want to give, say, like maybe a 500 ml bolus, and then I maybe want to give a diuretic as well. Diuretic is going to help to get rid of some of those kind of peripheral fluids. So if you ever see like, it may seem counterintuitive, like, okay, well, they're intravascularly depleted, but I'm giving fluids along with a diuretic, doesn't make sense. But that's really trying to help get rid of some of that extra fluid there that have built up, So you may see like 20 milligrams of Lasix or something, usually a loop diuretic, given to help kind of kick off that fluid, that diuresis essentially, right? Anywho, yeah, so sometimes you need a lot of fluid to help resuscitate these patients, and so especially in trauma bays and things like that, you're going to see a lot of fluids available. So the question, how do you get it into the patient, right? So lots of different ways we can do this. So you can kind of notice the volume that you can actually put into the patient is dependent on the gauge of the needle you started, the cannula you have in. Obviously, if it's like something, and again, with needle gauges, usually smaller or bigger is going to be giving us, smaller or bigger gauge is going to be giving us more fluid flow. Smaller gauge, right? So you want to go with like a 16 or 18 gauge or something like that. Is going to give you a lot better flow than using something a lot higher gauge than that. Okay. So again, that's all going to be dependent on, again, as you increase the radius of that needle, you're going to be able to get a lot more fluid flow going through that. So usually if you have like a trauma patient coming in, might slam them with like 2 16 gauge needles and then let the fluids go wide open, right? When I say wide open, that means just let them run as quick as gravity will help them. Anywho, if you were to just hang a bag to gravity, you roughly can get around 120 mLs per minute or so. Okay, that's through a 14 gauge needle, so it'll be an even larger gauge there. So that's pretty quick, right? So how long would it take me to get a liter of fluids into a patient? Less than 10 minutes or so, right? So within 10 minutes, you can probably get a liter into that patient. If I have 2 lines going at the same time, I get 2 liters in within 10 minutes or so. That's going to be pretty quick a way to get that in. Some patients need even faster than that, right? So especially these trauma patients who are losing a lot of blood, who are losing a lot of fluids, we can use what they call a level 1 infuser. You might see this if you ever go to like ORMC or somewhere where they have a trauma center. You may see one of these level 1 infusers. You put your fluids in here, and they can infuse up to 500 mLs a minute. So in 2 minutes, I can probably get 2 liters into a patient. Craziness. Assuming I had 2 going at the same time. You notice here it's kind of 2 bays here, each one going into a different line. Other cases you may see pressure bags applied to a liter of saline. So you notice here's a little bag that will fit over the liter bag, and then you kind of puff it up. It's kind of like a blood pressure cuff. And in fact, if you were in a state where you don't have one of these pressure bags, guess what? I can just use a blood pressure cuff. I can just wrap that around it, tighten it up, and start to pump it up, and it will do the same feature here. By increasing that pressure, it should increase your flow. Okay. Now, most standard pumps, so say for instance, this is like a typical like Alaris pump we would use, like in the, this is the ones we use at Nemours. Their max that can go is 999 mLs per hour, right? So again, to get a liter in, it's going to take me an hour. And for some patients, that's not going to be appropriate, especially adult patients. So oftentimes, we'll just hang it to gravity and just let it go in on its own. Okay. For kids, when we're trying to make sure we're getting a very exact dose into our patient, we can't just use like a liter, especially if you have like a little neonate or somebody. We'll actually use what we call a push-pull method. We'll actually have a 60 cc syringe, and we'll just draw up doses out of a bag and then just infuse that directly into the patient. That way we get a very exact dose rather than just hanging a bag and just kind of guesstimating it. All right, so several ways to get that into the patient, but a lot of it goes back to how big of a gauge needle you have, how easily you're able to get that fluid into the patient. Okay, well, what if you can't get an IV? These 2 young fellows, the eager, productive members of society. There's lots of options, right? So you have a couple of options here. So imagine you can't get an IV. This is especially important for pediatrics or patients who maybe just have really poor veins. Because again, if you're intravascularly depleted, does that make it more difficult to get an IV? Absolutely. Those vessels are not going to be very well plumped up. You're not going to have a hard time getting a needle in there. So that can be difficult. So you have things like interosseous access. So you basically have a little power drill. You'll just take this and do you guys know where you use the IO at? Typically the tibia. Anywhere else? Sternum you can also use. Those are the most common ones. I think I've seen like the humerus, you can use it potentially, but those are the main places. Tibia is the only one I've really seen in practice. But based on the size of the needle, depending on what bone you're going into, the size of the patient, they say you can get right into the bone there, go infuse your fluids right into the marrow, and you can infuse it just as fast as you would through an IV. So that's another very good way to get access very quickly, especially if you're like in a case where pediatrics, something like that. Oftentimes these will already be started by paramedics by the time they get to the ER. Has anyone ever heard of hypodermal crisis? Does anyone ever have like a dog or a cat they take to the vet and they get fluids? Yeah, this is basically what you're doing. This is basically sub-Q fluid administration. Sub-Q space can actually accept quite a bit of fluid, especially like in the areas like the back, places like that. You can get a lot of fluid into the patient, typically like normal fluid bolus amounts. And so occasionally what we'll do if I have a patient who they don't want to do an IO on, they're not that emergent, or they can't get an IV on, they'll do subcutaneous fluid administration. And so actually what we'll do before that, we'll give a drug called hyaluronidase. They typically don't do this for animals, but they'll use this. And hyaluronidase will actually break down some of that connective tissue in the sub-Q space. So you would infuse this, allow it to kind of break down the tissue a little bit, and then you can infuse your fluids right into the patient. It might look like a camel for a little bit, a big hump fluid there, but then it will dissipate on its own pretty quickly. So again, we use that rarely, but it could be an option. So these are guys who are into extreme body modification. So what they'll do is they'll do the sub-Q fluid administration, they'll just kind of pop a little finger in the middle, and now they have a donut head. I don't get it, but different strokes for different folks, I suppose. Okay, and then once you get them adequately fluid resuscitated with your boluses, then now we need maintenance fluids, right? So this is going to be helping to maintain or replace kind of ongoing losses. Typical healthy adults, we mentioned, is roughly 2 to 3 liters per day, so about 30 to 40 mLs per kilo per day. That's typically why when you think of a maintenance fluid rate, you think of how much? 125 mLs an hour. And actually, I had one of the students who are on rotations right now. They're like, yeah, just do 125 for everyone. It's like, that's not right. Come on, you know better than that. But typically for most healthy adult patients, 125 mLs an hour usually equates out to be about 3 liters per day. So again, that makes sense why we're doing 3 liters per day when that's usually what they need for the most part. Now, can you go above that? Absolutely, right. So if you need to say like 1.5 times maintenance, 2 times maintenance, that's usually what they're referring to, either 1.5 or 2 times that 125 mLs an hour. Okay, so that's usually kind of your standard for adult patients. However, for peds patients, what do we use? 4-2-1 rule, which I've probably drilled into your head several times already. So again, remember that first 10 kilos, it's going to be 4 mLs per kilo per hour. For the second 10 kilos is 2 mLs per kilo per hour, and then every subsequent kilogram, 1 ml per kilo per hour. I'll have some calculations on the end here. We can kind of work through those real quick. So what fluids should I use to help replace or to use for these maintenance purposes, right? So one of the things I mentioned already is that iatrogenic hyponatremia we induce in a lot of patients. We mentioned, especially those that are having a lot of pain or on certain medications or they're inflamed, they tend to be at a state where they're releasing more ADH than they would otherwise normally do, right? And we know that ADH does what to serum sodium? It's going to decrease, right? Because it's going to try to hold on to more water. You're going to try to dilute things out, essentially, right? To decrease that osmolality. So what a lot of people end up doing kind of as just kind of second nature is they'll start a patient on D5 half with 20 of K, right? It's a very common maintenance fluid you'll see a lot of patients started on. However, we do see that when you use that half normal saline, and anyone remember the concentration of sodium in half normal saline? It's about 77, right? Because in 154 is normal saline, so 77. And normal serum sodium, we already mentioned, is around 140. So 77 is less than 140, so if anything, you're diluting out the blood. So again, you're at higher risk when you use a hypotonic fluid like D5 half, and again, that may be good for some patients in order to help kind of rehydrate some of those intracellular spaces, but you are at risk of developing that. And again, there's no easy way to determine a patient's ADH levels, and so because of that, you can run some risk. You are typically safer if you use something like D5NS with 20. Okay, we'll look at the potassium in a minute, but typically D5NS is going to be a little bit safer unless your patient, say for instance, they're any reason they don't need to be on that for their hyponatremic or something that may not be the best option for them. So typically dextrose, typically 5% for most patients. Again, this is to help provide calories when the patient is NPO and they're not taking any food in. Now, the question is, well, how many calories are they getting per liter here? We can actually do that calculation. So looking at D5%, remember how we figured out how many milligrams per ml there were of a concentration when you see it like that? Remember, you just move the decimal place over one spot? So with D5, I know there's basically 50 milligrams of dextrose per ml. right? So 50 times 1,000 mLs in a liter is what? 50,000 milligrams. So 50,000 converting milligrams to grams is what? 50 grams. So basically there's 50 grams in that whole bag of D5, okay? Well, how many calories are there per gram of carbohydrate? And for proteins, it's 4 calories per gram. Remember, for fats, it's 9. And for carbohydrates, it's 4, right? So again, remember, carbohydrates and proteins typically have about 4. Some people may say like 3.6. I just like to use 4 because it's a good round number. So if I know there's 50 grams of dextrose in the whole bag, and there's 4 calories per gram of carbohydrate, there should be 50 times 4, 200 calories in the whole liter bag. So again, it's not a lot of calories, but it's just enough to kind of prevent ongoing catabolism for the patient, okay? So again, that's something you want to take into account, especially if you're dealing with a diabetic patient, because again, their sugars will be running high anyway. But if someone is coming in and say they're hypoglycemic, in some cases, you may have to use even higher concentrations, something like D10. And more frequently in neonates, we'll use a lot of D10 for those patients because they are higher risk for having hypoglycemia. So that's one thing to note there. Anyway, other additives you might have, like for potassium, typically 20 to 40 milliequivalents per liter. Obviously, if they're already hyperkalemic, you don't want to give any more. You want them to get back down to a normal range for you to add that in. And then usually we will avoid LR for maintenance fluids, because remember that lactate gets converted over to bicarb eventually. You don't want that to keep running continuously because it can lead to alkalemia. We don't want that to happen. So normally NS containing fluids or sodium containing fluids are what our maintenance fluids are going to be running off of. Okay. Okay. So monitoring, what do we do for monitoring for these patients and their fluids? Let's look at the physical exam. We can look for things like edema developing. We can listen to the lungs to see if they sound kind of junky. Vital signs are really good as well. So for instance, for our patient case, if we were to adequately fluid resuscitate him and start him on maintenance fluids, what would you see with his vitals? Blood pressure come up and the heart rate should come back down. Good. That's what I would expect to see. You can also look at the serum chemistry, so like the BMP, osmolality, urinalysis. All these can be very useful in helping to monitor these patients. And the other big thing, look at is urine output, right? So again, urine output, it's easier if they have like a cath in where you can actually measure it directly, but in some cases, especially for kids, we'll measure diapers. For adult patients that may be peeing into like a urinal, we'll just go ahead and collect that hopefully before they flush it and measure all of that. Typically for adult patients, if you're between 0.5 and 1 ml per kilo per hour, that's a good sign that they are eliminating those fluids adequately. They can go well above that, that's fine, but they're much below that, you're concerned about kidney function, right? And for peds, you want to shoot for 1 ml per kilo per hour at least. You can go well above that again, okay? That's showing you that, again, they're going to be outputting fluids at a good rate, so that way I'm not giving them too much on the internally, right? And my input is not going to outstrip my output, essentially. So, and the other big thing you want to know is like get patients off the IV fluids as soon as you can, right? Because again, having an IV in place, is that a risk-free sort of situation? What can happen? Infection, right? So I don't want them to have an infection, and the sooner they get the IVs out, the sooner they can go home too, right? That's kind of one of those steps towards discharge. And a lot of people end up staying on IV fluids far too long, and so one of the things to note is once their oral intake is adequate, go ahead and get them off the fluids. They don't need it anymore. If they're able to take in, start a normal diet like that, they don't need fluids anymore. Get them off of it so that way they can get the IV DC'd hopefully, and then move on to eventual discharge. Okay, so back to our case. Again, we've reviewed this a few times already. So what kind of fluid bolus did he receive? We already mentioned. Normal saline, how much? 1 to 2 liters. Perfect. How quickly should I get that? Just say run to gravity. You can sometimes put that in. That way it'll just kind of run. And usually within 10 minutes or so should be in. So that's a good place to start. Again, 1 to 2 liters is a good amount. If you're worried about kidney issues, if you're worried about edema, things like that, then you want to start probably half of that, maybe 500 mLs to a liter, depending on how the patient's responding there. Again, I can always give more. I can't take it back necessarily. Let's see. Other fluids you might see occasionally. So for instance, if you have someone who's in DKA, which stands for diabetic ketoacidosis. And I'm sorry, do you guys mind if I just go ahead and go through without a break? I only have 7 more slides. Is that okay? Mostly just cases and stuff, so it shouldn't be too bad. Anyway, so the DKA method, sometimes we'll actually use 2 bags in order to help manage a DKA patient. Because DKA patients, typically they're insulin deficient, right? And they what does their pH typically do? Diabetic ketoacidosis, you'd assume their pH is pretty low. So this is something where we actually have to include fluids in order to help to account for that. The other big thing is like you don't want to not give them any sugar, even though their dextrose is probably their glucose is like 400. You need to still make sure they're getting some sugar because when I give them insulin, that's going to drive that sugar into the cells essentially, right? So typically what I might do for those patients, I'll do something like D10NS with 20 milliequivalents of K-phos. So K-phos just being potassium phosphate, because then usually those patients in DKA, they're diuresing a lot and they lose a lot of phosphate there. And then 20 milliequivalents of KCl. Okay, so I'll kind of mix those two together, and then I'll mix it with a second bag. I'll have another bag running concurrently. It'll just be NS with 20 milliequivalents of K-phos and then some KCl as well. So what I'll actually do is I'll be running both of these together at the same time, and based on the ratios between the two, I can change how much sugar they're actually getting in through the IV. So for instance, if I'm running these both in at half rates, that actually kind of will dilute out the D10 to be basically D5. So if I see their sugar is, say, staying too high and it's not coming down quickly enough, I'll go ahead and put more of the NS going and then cut down on the D10. Or if their sugar is dropping too quickly, which you'll learn in DKA that you don't want to correct the sugar too quickly if it's been a few days due to cerebral edema concerns, then you can basically run more of the D10 and shut off some of the NS. So by changing that ratio, you can kind of affect how quickly their sugar is dropping down, which is very important, especially in those early days. And then in some cases we'll add K acetate instead of KCl if the pH is below 6.9. And what does the acetate do for us? Turns into bicarb, right? So again, they're acidotic, their pH is below 6.9, which again, is that really compatible with life? Not in the long run, right? We want to correct those pHs as best we can. We'll give them some K acetate that will help to actually correct that, right? Anyway, for acidosis, very frequently you may see sodium bicarb being given in these bags, so we'll do something like D5 with 150 milliequivalents of sodium bicarb. Now the thing with this is, notice there's no sodium chloride we add to that. Why is that, do you think? How much sodium is in that bag at that point? 150 milliequivalents of sodium, right? For a liter bag of D5. So, and we mentioned normal saline has how much? 154 milliequivalents of sodium, right? So I'm basically making a normal sodium amount within that bag by giving just a sodium bicarb. The only thing I'm missing is the chloride, which if the patient has acidotic, they don't necessarily need more chloride. Make sense? If you ever see like a bag of D5 with 150 milliequivalents per liter of sodium bicarb, that's what they're doing it for. They're doing trying to alkalize the blood, try to get the pH up essentially. Okay. All right, some other fluids you might run into, things like 3% sodium chloride. I mentioned it's very concentrated sodium. This is good to draw water out of the intracellular space and into the extracellular space. Right, so I probably should correct that. It's good for cerebral edema. As I mentioned, you can pull fluid off of there if you have like a head trauma patient or something, and then correct hyponatremia, especially if they're having like hyponatremic seizures, things like that. You can correct it pretty quickly there. Okay. Albumin's good for increasing those oncotic pressures. If you ever have to give albumin D5, you can just give as like a normal fluid bolus. I can give 20 mLs per kilo of that. So if I give them kind of repeated courses of normal saline and I want to give them something different, I give albumin 5% at 20 mLs per kilo, same dose essentially, right? Or if they're fluid restricted and they need that oncotic pressure and they maybe have low albumin levels, I can use 25%. It's just more concentrated, get more proteins in there. Usually use between like 0.5 and 1 gram per kilo essentially. So usually you're going to see that more in renal patients. Okay. All right. So moving on, let's look at case 2. Let's say we have a 1-year-old 12-kilo child presenting to the ER, suffering an anaphylactic reaction secondary to a peanut exposure. You see he's got a heart rate of 160, blood pressure 73/42, and a respiratory rate of 40. What do you think? Sick? Not sick? Sick. Sounds pretty sick, right? Based off of? Tachycardia, blood pressure, respiratory rates pretty elevated. Okay, so this is the class where I get to call on you guys to come up and write prescriptions, right? No, I see a lot of no's going on. Let's see. Who'd like to volunteer to write me some ER orders for this patient? Again, this is it's a judgment-free zone. This is a safe space. Any volunteers? Do I have to call on somebody? Oh my goodness. Let's see. I'm gonna call on. Let's do Mr. Kevin Show. Call on the back row boys. Come on down. Thank you. Thank you. I didn't want to have to do it, but you guys forced my hand. Thank you, sir, for being so gracious. Okay, so let's help him out with this. Let's walk through the process, right? So write ER orders. So this isn't like a typical prescription where we have to write quantity to dispense and all that good stuff. These are orders we're going to be handing over to the nurse, and the nurse is going to be acting on these pretty quickly, right? So for instance, let's start with fluids. How much fluid do we want to give this kid? So it's 12 kilos. How much do you want to give him? 20 mLs per kilo. All right, so 20 times 12. 240 mLs. All right, so you can do, so what fluid do you want to use? Yeah, this is normal saline, so go ahead and write NS. You can write 0.5, I'm sorry, 0.9, 0.9. Always want that leading 0. NaCl. Good. And then you want to write your volume you're going to give. So we said 240 mLs.
Next line.
You can put it all on the same line. It's fine. 240 mLs. And then what's our route? IV. Good. So you write IV. And you could write, say, run to gravity. That would be fine. In some cases, you may, for a really severe case, you may say IV push. IV push will denote that you're giving it very quickly, right? So I'm not going to be hanging it up to, on a pump or something like that. So in this case, it's pretty serious. Yeah, I'll probably do IVP. Your IVP would be IV push, right? So that will work for that. Okay, so good. That's our first order. The nurse says, okay, let me go get that bag out. We're going to push 240 mLs of NS into this child. Okay. What's the next med we're going to need? We need epi, all right? Okay, kids hypotensive, we're going to need some epis. How much epi do we use? Who's got their drug dosing out? 0.01 milligrams per kilo of epinephrine. So again, can I write 0.01 milligrams per kilo? I don't want to write that. I want the actual dose based on the patient's weight, okay? So how much is that going to be? 0.12 milligrams. Good. 0.12 milligrams. Epinephrine. You just write epi for our purposes here. We'll just abbreviate it, even though you end up writing epinephrine is fine. And then what route do we want to give that? I prefer IM for these cases. Now, if the kid was coding, you could definitely do IV. But in the case like anaphylaxis, some people do sub-Q. I don't like that. You don't really get, they're hypotensive. Like if you're not delivering a lot of blood flow to the area, you may have kind of erratic absorption. IM, you're more guaranteed to get that full dose. So let's go ahead and do 0.12 milligrams of epi, IM. My question is, what concentration of that do you have to use? Because there's two main ones you're going to find out there. If you're running like a code, and you have a code cart, it's usually going to be the 0.1 milligrams per ml concentration. But for this, we're using IM. Do you want it more concentrated or less concentrated? You want it more concentrated, right? So this one we're actually going to use the 1 milligram per ml concentration. Okay. So you could write, typically you wouldn't have to write that necessarily. It would be kind of figured out for you. But just know that you want the more concentrated form. You write 1 milligram per ml. Okay. There you go. Perfect. Now this one, the other thing I forgot to mention here, you also want to write the frequency, right? So in this case, for the normal saline bolus, you just want to do 1. Okay, so you can just write once. So for that, you can just write once at the end there. After the IVP, yeah. And the epi, how much you want to do that? It just times 1. We'll do it. Yeah. So you can either do times 1, you do once. That's fine. You do on the second line. No worries there. Fantastic. Okay, what's the next drug we want to give? We could do steroids. What's going to be acting a little bit quicker?
Benadryl.
Benadryl. Let's give some Benadryl. Absolutely. Anyone know the dose of that? So the nice thing about peds is that most doses, if you're not sure, 1 mg per kilo is usually going to get you most of the way there, right? So again, for Benadryl, especially a sick kid like this, I can do 1 mg per kilo, okay, which means I'm going to get how much? So 12 milligrams of Benadryl. What route am I going to do this? IV, right? So again, it seems odd that you're going to use like epi-IM, but really epi-IV is really only going to be used during either like a continuous infusion or like during a code. So this isn't really at a code sort of state yet. We can do IM. However, the Benadryl, definitely want to do IV. And again, that would probably be IV push as well, so you can kind of denote that. And then again, that'll be once. What's the generic for Benadryl?
I don't know how to spell that.
Don't say it to your patient like no. Diphenhydramine, right? That's okay. Benadryl's good. And then what's the last drug we're going to give? So he says steroids, and we know what we want to use? Methylprednisolone. I like that one. That's a good one to use, right? And what's the dose? 1 mg per kilo. Absolutely. We can give away 1 mg per kilo. Let's go and do 12 milligrams. The methylprednisolone, IV. You know how often? Just once, right? So again, this is the ER orders, right? So typically ER orders are a one-time sort of deal for the most part, right? Yep, we'll do that push too. Why not? For a lower dose like that, it's not going to be a big issue. You have like sometimes like RA and stuff will get like huge doses and you have to slow it down. But so there we go. So we got our 4 met. Anything else you think we could give? What if we want to do maintenance fluids? So say the kid recovers, blood pressure comes up, heart rate comes down. We want to get him admitted to watch him overnight. What are we going to do? 4-2-1 rule. What kind of fluid do you want to use first, though? Normal saline, just normal saline maintenance? D, yeah, because again, this kid's probably not going to be eating overnight, so you need to include some sugar, right? You need to make sure he doesn't get hypoglycemia. So D5 with normal saline. Yeah, so I like normal saline. A lot of people may do just D5 half. Honestly, probably won't matter for this kid because he's going to be on a short term most likely. Let's do D5 NS. Do I need to include potassium? Not necessarily. This kid's probably not one that's going to be like wasting a lot of potassium like a DKA patient would. He just had a kind of an acute sort of event that occurred here. So you could go without the potassium. It's no one going to fault you if you include it. Okay. So you do D5NS, and how much do you want to give? So 4-2-1 rule. So for the first 10 kilos, we get what? The 40 mLs an hour, and then for the next 2 kilos, 2 times 2, so 44 mLs per hour. Good. So just D5NS. You want to do IV? And when you just do IV, and then you go 44 mLs per hour. Now you don't have to include a frequency on that because it's per hour. It's kind of understood that it's continuous, and you can just kind of leave it like that. So you just write D5NS, IV 44 mLs an hour, and you're kind of set. All right? Until you discontinue that order, it's going to just run continuously. Okay? That makes sense for everyone? And these would be how you'd write these orders in the ER, and then of course when you go into the inpatient setting, they want to continue the medications. You might do like methylprednisolone like Q6 hours. The epi they would only probably need the one time unless became more severe. It might do Benadryl Q6 hours while they're there. But yeah, so that's pretty much it. So any questions on that particular case? Give a round of applause to Kevin. He did such a great job. Wonderful, fantastic. You guys feel comfortable with that? So see kind of the difference between like an actual prescription order you might write versus for filling out like a CVS or Walgreens versus like the inpatient order that the pharmacist, if you're doing like this via EMR, the pharmacist would get that order, we would verify it, and then the nurse would go pull it from the machine, Pyxis or something, and get that drawn up and administered, right? Or if you're lucky enough to have an ER pharmacist, they might draw it up for you, and then you have all the doses right there, right? Okay. Let's say, for instance, we have a 28-year-old woman who weighs 65 kilograms. They're admitted to the ER, the diagnosis of acute appendicitis. Have a poor history of poor oral intake. They receive a 1 liter bolus of normal saline in the ER. And vital signs and electrolytes are otherwise normal. What type and rate of maintenance fluids would you want to administer once they get up to the floor? Assuming she's going to be NPO essentially. So what do we think? I should probably call on someone else. I'd hate to just single out Kevin and make him the only one. So let's see. Let's do Miss Heidi. Where's Miss Heidi at? There she is. All right, come on up. You're not down, you're up. We're lifting you up together. Providing moral support from the background, right? This is not so good. I have this stuff. Let me try that. A little bit better.
So we're doing maintenance.
Sorry, my fault. Not used to work on the microphone, but yeah. So they already got the bolus in the ER. So now we're just working on the maintenance fluids.
So that's the 30 to 40 milliliters.
Yeah. So the question is, what type of fluids do we want to use first with this patient? So electrolytes are totally normal.
I would just say normal saline.
So do normal saline. Now remember, the patient's going to be NPO because they're about to go to surgery for the appendectomy and then come back out. Yeah, so this is another case where we want to include sugar because otherwise the patient's not going to get any calories and then could go hypoglycemic. We don't want to do that necessarily, right? So that's dry enough. But okay, so we want to do D5, half or normal saline. Some people may do half. You can't go wrong with doing normal in this case, right? Because again, there's no contraindications to it. So I'd say D5 normal would be fine. You want to include anything else? In this case, I might add some potassium in there as well, because again, we want to prevent any ongoing losses. She's going to be NPO for at least a day or so, so you want to be considerate of that. So maybe I'll do D5NS plus, and then we do how much potassium? Yeah, so you do 20 MEQs.
Do I have to look? How do you write that?
So you do D5 half, or I'm sorry, D5NS, and then you do 20. Yep. You do little m, big E, little q, then slash liter. All right, so do D5NS with 20 milliequivalents per liter, and then KCl. Or CLUS. I had a patient come up to the pharmacy one time and ask for it. I'm trying to get the refill. Right, so this should be little L, because we're not giving them like, I don't know, lanthanum or whatever that would be on the periodic table. Lithium is Li, but KC little L. Okay. Good. Now, what rate do we want to give that at? Now, could you use a 4-2-1 rule? You could, but most people probably wouldn't do that for an adult patient like this. It doesn't have any other kind of like contraindications. So, what would be a maintenance rate? 125 mLs an hour. Could not go wrong doing 125 mLs an hour, right? So you can just do, yeah, so D5 NS 20 MEQs per liter of KCl, and then you write IV. So you always want to include your route. Then we're going to do 125 mLs, well, close enough, per hour. You can obviously tell I've only done this once, and we're having so many technical issues. You get the point, right? So 125 mLs per hour, right? Make sense? So again, very straightforward kind of orders. Again, you don't have to write a frequency on fluids like that because they're going to be running continuously. So as you write 125 mLs per hour, that is implied that's going to be running continuously. Okay? Any questions on that? Okay. Let's thank Ms. Heidi for her service. Great job.
I'm gonna go get you a paper towel for this.
Okay, that'll be good.
Or a little better.
Is this useful? You guys, is this
Yeah.
reasonable? Okay. Let's do case 4. Let's say we have a 75-year-old man. It's going to get a little more complicated. He's 80 kilograms, presents to the ER, symptoms consistent with a stroke. Severe headache developed followed by confusion, hemiparesis on the left side. He's a long-standing hypertensive patient, takes an ACE inhibitor. On exam, he's euvolemic. He's got elevated blood pressure 150 over 100 and normal serum electrolytes. So at this point, what type and rate of maintenance fluid do we want to administer? And the patient is going to be receiving nothing by mouth for evaluation and management of that possible stroke. So who should I call on next? So back to the males. Let's see.
Tell me what to write, I'll write it.
I can help walk you through. I just didn't want to make you walk up here. Are you volunteering?
Yeah, I'll volunteer.
Bring it on up. Let's do it. Let's do it. Now I just feel bad. Nails the point.
Now you're really gonna tell me what to write.
Yeah, exactly.
Yeah.
Like Tiny Tim.
Okay.
It's Christmas Day.
Didn't know Tiny Tim had a bun. It's cool.
It's a messy bun. Yeah. Okay. So, all right. So we have our stroke patient here.
Okay.
Has normal electrolytes. So the question is, what do we think as far as what type of fluid do you want to give him? A D5NS. So the one thing you want to consider here as well is, again, fluid shifts, right? So for a stroke patient, primarily CNS issue, do you want fluid to shift into the CNS? You don't, right? And again, this might be someone who, again, due to kind of their critical illness, maybe at a higher ADH sort of secreting kind of state, which is going to do what to our sodium anyway? These are going to want to decrease it, right? It's going to want to decrease that sodium concentration by making the blood more dilute. So if I use something like half NS, which is only 77 milliequivalents per liter of sodium, you're going to find that is going to have a tendency to put water where? Towards the intracellular space, and then in this case to the CNS, right? So again, that's one, because at that point, CNS is more concentrated than what would be actually putting into the veins, essentially, right? So this would be another case where I probably want to stick with D5NS, because I do not want to cause shift into the CNS at all, right? So in this case, let's do, we have stroke patients, let's go ahead and do dextrose 5%, right? So D5. He's going to be NPOs, we want to keep him have some calories. We're going to do NS. Now, do you want to give him any potassium? No? So, what might be affecting his potassium? His ACE inhibitor, yeah, it should do what to the potassium? Yeah, ACE inhibitor should actually increase it. So, this is one of those things where you're not starting a new ACE inhibitor on him, so you can kind of see what his potassium is to begin with. If it was already at 5, would I want to give the potassium at that point? Probably not, right? He's on the high end of normal. I wouldn't want to do that. However, it came in as like 3.5, 3.3, something like that, then I would feel okay giving it. At this point, it's probably kind of plus minus if you were to administer it. Again, you're going to be doing serial labs on this patient anyway, so by the next morning, you can kind of reassess where he's at and change fluids if you need to. That's totally fine. So let's go ahead and hold off on the potassium for right now. Let's assume it's going to be, it's normal now, but maybe high normal. So let's go ahead and hold off on that. And then how much do you want to give him? Does he have any kidney issues? He's euvolemic. So I don't need to worry about kind of rehydrating him. So a good rate would be 125 mLs an hour. Again, hard to go wrong in that case when you have a patient with at least good functioning kidneys for the most part. And then what's our route? IV. Perfect. And that's pretty much it, right? Fluid orders is real easy. Okay. It's just a matter of just making sure you're selecting the right ones for your patient and the right rate. Okay.
Just fluids on this guy?
Just fluids on that guy. That's all we had, right? That's why I think the first one was complicated, because I knew you guys were experts at treating anaphylaxis. Thank you so much. Miss Kelly? All right. I think I don't know how many more cases I have. Just a few. You guys okay? Don't need a break? We're almost done. All right, so this one, again, a little bit more complicated. Let's say we have an 87-year-old man who's weighing 70 kilos. He's got left lower lobe pneumonia, admitted to the hospital from the nursing home. He's got a history of myocardial infarction, well-controlled CHF. He's on an ACE inhibitor, beta blocker, thiazide, sodium-restricted diet. Again, this is like an easy patient compared to some of the ones you'll run into, right? He's got 500 ml of NS during transport. Vital signs are stable. No evidence of pulmonary congestion. No peripheral edema on examination. So it does not appear to be fluid overloaded. Appears to be uvolemia, at least at this point. Electrolytes come back. He's got a sodium of 134. He's got a potassium of 3.2. Carbon dioxide of 31, creatinine of 1.2. Let's see, you can tell I pulled this from a British website because they use micromoles in some cases. And we're going to start some intravenous antibiotics as well. So this one's going to be a little bit more complicated from that standpoint. You don't think he's going to be well enough to drink fluid, so we're going to go ahead and start him on some IV fluids here. Okay, any volunteers? All right, let's see. What about Mr. Ryan?
You know my head, right?
Huh?
You know my head.
That's perfect reason to get up here. We're going to help to decipher it together. It's mostly just like single letters and numbers. It'll be fine. It'll be good. So while he's walking up here, what do we think about antibiotics? What would you start on a guy like this? 87-year-old guy coming from a nursing home. What do you think? Broad spectrum antibiotics, right? You're thinking there's going to be some nasty bugs growing here. What bugs might you consider covering? MRSA and Pseudomonas, right? You got to cover it because, again, this is more of a healthcare associated sort of pneumonia when you're coming from a nursing home, right? So, for instance, with Vanco, I'm sorry, I gave away the answer there. So, let's say, for instance, I want to start an IV antibiotic for MRSA. I could go with Vanco, sure. What if I was worried about his kidneys? I want to use something non-renally eliminated. Yeah, Zyvox or Linazol would be a good option for that. I would also cover the MRSA. Now, how about the gram-negative side of things? Gentamicin. Okay, so aminoglycoside is one option. What else could I use? Remember, we're dealing with Pseudomonas, so what do I have to think about? Pseudomonas, you double cover, right? For these type of patients, when you're going broad spectrum, you need to double cover. So I could do gentamicin plus, say piptazo? Yeah, herpiptazo. So gonzosin would be a really good option there. What else could I use? Cefepime would be a good one, right? So you want something like a beta-lactam plus something else, right? So again, I could do like a beta-lactam plus a fluoroquinolone, which may not be good for like a renal patient. Neither is really aminoglycosides, but I can do that therapeutic drug monitoring on that. So, I could use gentamicin, I could use levofloxacin, be an option from a fluoroquinolone. What else? Anything else I could use? What about my carbapenems? Remember any of those? Yeah, meropenem would be a good option too, right? That could cover that, especially if he has any history, like resistant bugs or anything like that. That's a really good one to use as well. So I mentioned cefepime, piptazo, meropenem, fluoroquinolones. Yeah, so those are the main things you would think about as far as antibiotics. I'm not going to have you dose all those right now. However, all right, so what do you want to do for fluids? So start off, first thing is going to be first component. Do you want to give him any sugar? No? Why not? He's going to be NPO. Yeah, I'd probably do it. I mean, we have no sign he's hyperglycemic at this point. Otherwise, if he was, you might want to hold off on that. Okay, so let's go ahead and do D5. That'll be the first component. And do you want half normal, normal saline? What do you think? Why normal? Yeah, his sodium's already slightly low to begin with. It's already 134 millimoles per liter, which is the same as milliequivalents per liter. So you could do something like NS at this point. So D5, do NS. Whoever's laughing, I'm going to call on you next, so just keep that in mind. Rude. Yeah, very rude. He's putting his heart out on the line to people. Yeah. All right, so we got D5 NS. Now, at this point, do we want to add any potassium? Why do we think so? He's low. It's 3.2. What do we say is normal? 3.5 to 5, right? So again, normally we want to add some potassium here. You could do probably, for someone like this who's like a little bit more, older patient, a little bit sensitive, I would probably only do like 20 milliequivalents per liter there. So next you were going to write 20 MEQ.
Small e, right?
Well, remember it's little m, big E, little q.
Just write your left hand.
If you really want to see bad, you'll have me write with my left hand. You'll see. Then that's going to be per liter, so slash big L. Yep. So 20 milliequivalents per liter, and then you're on KCl. And little l. There you go. Yep, that's perfect. So again, that's going to be our fluids D5 NS with 20 milliequivalents per liter of KCl. And what kind of rate do you want to give it? You want 25 mLs an hour? What do you think? This creatinine doesn't look too bad. It's like 1.2. you know, but you have to kind of investigate, like, why they only give him a half liter coming on in, you know, like what's going on with that, you know. But if he does not appear to be edematous at all, you know, creatinine, we'd want to know what his baseline creatinine is. Is probably if that's 1.2 for a guy this old, like I'd expect him to be running higher anyway. But yeah, I think 125 mLs an hour would be totally fine. So you want to write your route, the IV?
No, I mean, here.
That's fine. And then, yep, 125 mLs per hour. Now, in the real world, how do you think you'd be doing all this? On the computer, you'd be clicking off your boxes, everything would be kind of pre-checked for you, you'd be going through this pretty easily. So again, we're just having you write it out now, so let's get that experience a little bit. So, perfect. What do you guys think? Good? All right, thank you so much. Fantastic. Just that easy. Okay. So we can work through these real quick together, some PEDS calculations. Thank you for all my volunteers. Yes, ma'am.
Why did you say to add the potassium in case 3 again?
So which one's case 3? The appendicitis. Well, so if for that one, like, so assuming they're going to go to surgery, I don't know when they're going to go to surgery, maybe like a day or two. You know, they're going to be on IV fluids, especially like the post-operative period. I want to make sure I'm kind of covering those losses, right? And you get a feel for that sort of thing, you know, depending on where you work and kind of what your experience is. But like the anaphylaxis case, you know, the kid's going to be probably overnight observation, and then you're going to send them home. So I'm not too worried about the potassium in that case. For someone that might be a few days they're on IV fluids, then I'd want to go ahead and think about those ongoing losses. And so putting 20 milliequivalents per liter of KCl in there is going to be fine. That makes sense? Yeah. Otherwise, you're going to recheck their labs and then hypokalemic, and then I have to add it back in.
So what if the patient that we just did was slightly edematous?
Mm-hmm. Then I would probably only start like maybe half maintenance, or I might actually maybe hold off on fluids until you just kind of see what their course was going to go like, right? You know, I don't know that diuresum necessarily, but again, you're going to have to kind of see how the clinical course is going to go at that point.
The alternative to 125 milliliters per hour for that case?
Yeah, so what would be the alternative? So if I did not want to start a maintenance, I could just do what? Well, that gravity is going to go in like 120 mLs a minute. All right, I don't want that. You could do that, or I'd just probably do half maintenance. You know, instead of 125, maybe only do like, you know, somewhere like 70 mLs an hour. You know, that would be totally fine as well. You could totally do that. So again, I can always give more. So if I tried to start him at 70 mLs an hour and he was, you know, appearing dehydrated hours later, and go back and give some more. Yeah, for sure. Okay, so let's say for instance we had a PEDS patient who was 4 kilograms. What would be their maintenance rate? 16 mLs an hour. Good. How about 54 kilograms? So 40 for the first 10, 20 for the next 10, so we're already at 60. And how much do we have left over? 34. So 60 plus 34, 94 mLs an hour, right? And you can do the boluses too, just do 20 times the weight and get those as well, right? Let's say, for instance, I have 17 kilograms. It'd be 54, right? Because I get 40 mLs per hour for the first 10, and then I get 7 times 2, so it's going to be 14. So you get 54 mLs an hour, right? And again, you'll be able to do these like in your head, especially if you work with PEDS on any regularity. You'll be able to do these, just bang them out real quick. How about the 102 kilo patient? So they're going to start, so just do the math. So you start out with 40 plus 20, and then how much do we have left? I have 82 left over. So 60 plus 82. Yeah, so again, you're pretty close to a normal maintenance adult rate at that point. If you wanted to start at 125 mLs an hour, no one's going to fault you. But you could always start at 140. It's probably not going to make a big degree of difference, right, for most healthy patients. Okay. And again, you think, that doesn't sound like a PEDS patient, but yeah, I mean, especially being over at the World of Sports at Disney, we have you know, lots of competitions that go on. We have a lot of football players that get banged up. They have to come over to the ER. You know, that's our contract at Nemours. We get all those patients from Disney, and so you'll see patients that big all the time. So it's not an uncommon thing. How about a 1,200 gram patient? That'd be 4.8 mLs an hour, right? Because again, 1,200 grams is what? 1.2 kilograms, right? Perfect. Okay, and then let's say we have a 48 kilogram patient. 88, so 40 plus 20 plus how much do we have left over? Yeah, 28, so you're going to be 88 at that point. Good. And then 23? 63, perfect. Does that make sense? Yes, Ms. Heidi. Yeah, so again, 1,200 grams, if I want to convert that to kilograms, I just divide by 1,000, essentially, right? And so it ends up being 1.2 kilograms. And so you'll see that very frequently. You have to be careful when you're working with like NICU patients because they'll frequently put them down as grams instead of kilograms, pretty commonly.
I'm a student.
Hey.
Don't
Hello.
mind me.
So, any other questions? Any thoughts, concerns? That's pretty much all I have. Thank you so much for your time. If you have any questions, feel free to go beat me up in the hall or something.